ultrasound. Typically, you'll see an intrauterine sac as early as 5 weeks from the last menstrual period. You'll see fetal cardiac activity as soon as the fetus is visible at about 5.5 weeks or so. Cardiac activity should be seen by the time the fetus measures about 1.6 centimeters, and we call that the crown rump length, the measurement from the baby's crown to the rump, which is what you can see on ultrasound. Once that hits 1.6 centimeters, we should see the heart beating by then. You may need to do weekly ultrasounds to follow this serially. The first time you see a patient, they'll come in, they'll have some bleeding. You do an ultrasound, you see an intrauterine sac, but that's all you'll see. You'll repeat the ultrasound in a week. Within that week, we should see some growth and development in the intrauterine sac. Postcoital bleeding, and we see that quite often. The cervix, it becomes a little bit more friable meaning more likely to bleed when you're pregnant, so we'll see some spotting post-coitus. And ectopic pregnancy, as we previously discussed. Vaginal cervical lacerations, especially in instances of trauma or rape. Molar pregnancy, an unlikely cause of vaginal bleeding, but something you have to consider. And then, of course, non-pregnancy causes of bleeding, rectal bleeding, urinary tract bleeding, or anything like that. All right, once the diagnosis is secured that you do have a first trimester miscarriage, you have 3 main options. The classic one, or the gold standard, is called the D&C. You can also do expectant management. You'll wait for the body to take care of it itself. Or you can do a medical induction, the use of some sort of medication to make the uterus expel the products of conception, and that's typically misoprostol. Decision is based on the stability of the patient and then her desires and your comfort level. So the D&C is preferred when there's active bleeding occurring, whenever you know that there's not an ectopic pregnancy, or when the patient wants immediate resolution. The expectant management is preferred whenever the patient is stable and the patient wants little intervention. And then use of medications such as misoprostol combines the pros and cons of both of those and is a good option when quick resolution is desired without surgical intervention. So basically, the patient decides whether or not do they want to have surgery, how quickly do they want this taken care of, and what are my potential risks. You weigh those 3 options. All 3 are very good and very acceptable options. Second trimester miscarriages are not nearly as common as the first trimester, and since greater than or equal to 80% happen in the first, about less than 20% happen in the second trimester. And they're generally going to have more of an identifiable cause. Now, some of the etiologies of a second trimester miscarriage are infection, anatomic defects of either the uterus or the cervix, maternal systemic disease, fetotoxic agents, such as unrecognized pregnancy and taking chemo or something of that nature, trauma, having a hypercoagulable state, or the child has birth defects. And we'll talk about some of these. Treatment, generally an intervention is required whenever we have a second trimester miscarriage. They're not just going to pass on their own, at least not safely. Our main 2 options are a D&E, which is very similar to a D&C. It's just considered bigger. So anytime you're greater than or equal to 16 weeks, we call it a D&E rather than a D&C. And the reason why the E part's called for evacuation, because usually you have to reach up there and remove some of the products out using instruments rather than just using curettage. You'll need to prepare the cervix. In other words, to pass some of these larger instruments, you have to get it to dilate. So one of the common things we use is laminaria, which is dried seaweed. It comes in and it looks like little twigs or little stick form. You slide it up into the cervix. It absorbs the moisture from the vagina, and it swells just like a dried sponge. The other option is to do a labor induction. You bring them into the hospital and use high-dose Pitocin or misoprostol or another type of prostaglandin and induce the woman to go into labor and deliver. Decisions on those are based on the physician's experience and comfort level as well as the desires of the patient, but they're both equally good options. Take us a minute here to talk about RhoGAM. RhoGAM is a blocking antibody. It's given to Rh negative mothers, and it protects her from forming an antibody reaction to Rh positive blood. About 90% of the population in general is Rh positive, about 10% is Rh negative. So if the mom's Rh negative, there's a good chance that the baby is Rh positive, depending on the father of the baby. So if any of the baby's blood slips into her bloodstream, her antibodies will sense it as a foreign object and make an antibody response. What that will affect is any subsequent pregnancies. When she has an Rh positive baby, she'll have all these IgG antibodies against Rh positive blood. It'll cross the placenta and attack the developing baby's blood. And that's what we don't want to occur because that can be lethal. RhoGAM blocks that, and it should be given to any Rh negative mothers who have bleeding in pregnancy, whether it's an abortion, an ectopic pregnancy, or bleeding later on, even in a normal pregnancy.
Welcome back. Coming up with Valentine's Day tomorrow, what other sham holidays do we allow to control us?
Someone had a piece of bitter pie this morning.
Oh, God, Jane, I'm giving the news. You can talk about whatever drivel you want when we get to your segment.
But I have a secret for you, Cliff. Cupid has his sights set on you. Huh. Come on out. Cupid's sight. The causes for recurrent spontaneous abortion. Coagulopathy, uterine issues, PCOS, immunological causes, diabetes, substance use, stress, infection, genetic issues, hyperprolactinemia, and thyroid disorder. Cupid's sight.
Oh, good. For a second there, I thought you meant that you... No, never mind. It's too scary to think about.
What, Cliff? Don't pretend that we don't belong together. We were meant to be. Bill.
Hi, I'm Dr. Chris Lewis. It's time for your quick review. Let's get started. A 26-year-old female presents to the clinic with vaginal bleeding and abdominal pain. She has a beta HCG of 2500. Should you expect to see an intrauterine pregnancy at this beta HCG level? And if no sac is present, then what should you look for next? Well, this is a classic scenario. Someone's going to come in with vaginal bleeding, abdominal pain into your ER. You want to check a beta HCG. It's obviously positive, so she has some form of pregnancy going on. Well, the answer to this question is, yeah, you really should see an intrauterine pregnancy at this beta HCG level. Most of the time you're going to see beta HCGs of around 1500 being your cutoff of being able to see this. Now this is a transvaginal ultrasound and it's going to be operator dependent, so you need to have someone, an ultrasonographer who knows what they're doing, and you ought to be able to see something at that 1500 level. So at 2500 there really shouldn't be any question at all. If you can't find an intrauterine pregnancy at 2500, there's something going on somewhere. So if there's no intrauterine pregnancy, the next step is we need to make sure this is an ectopic pregnancy because we have the classical signs of vaginal bleeding and abdominal pain. Next question. In a normal pregnancy, the beta HCG level roughly should double how often? Well, every 48 hours roughly, your beta HCG level should be doubling. You're not going to get that same scenario with an ectopic pregnancy. Ectopic pregnancies generally don't double that often, and obviously if you have a miscarriage or something else going on, your beta HCG level ought to be going down. Next question. A 32-year-old patient has an ectopic pregnancy, but the patient is very stable and opts to take methotrexate. What instructions should you give the patient in regards to methotrexate? So she needs to stop all vitamins that contain folic acid because methotrexate is basically a folic acid inhibitor, and that's how its actions are worked out. You also want to minimize eating any green leafy vegetables or anything that has a lot of folic acid in there. So especially if this patient was trying to get pregnant, they were probably on prenatal vitamins. So just really hammer it home to them, look, you need to stop your prenatal vitamins. You can restart them when this whole process is over and when you want to restart trying to have a baby again, but for now, stop all folic acid. Next question. A 28-year-old patient presents with minimal vaginal bleeding. Patient reports that she is 12 weeks pregnant. On exam, she has a partially dilated cervix and ultrasound shows an intrauterine pregnancy but no fetal heartbeat. what would you characterize this miscarriage? Well, this is what we call an inevitable miscarriage or an inevitable abortion. The patient has not passed any products of conception but has a vaginal bleeding and a dilated cervix. Next question. A 25-year-old patient presents with very mild abdominal pain. Her vital signs are stable and her hemoglobin is in the normal range. She is unsure about her last menstrual period. Her beta-HCG is 900. Her ultrasound does not show an intrauterine pregnancy or an ectopic pregnancy. How would you manage this patient? So this is a really tricky one. This is the one where you're kind of sitting there. You can make one decision one way, make one decision the other way. It's not necessarily right or wrong. So the three most likely scenarios for this situation is, one, a normal pregnancy. So even people who have normal pregnancies, they can have some vaginal bleeding, and that doesn't necessarily mean that there's an inevitable miscarriage or something going on. It certainly puts you a little bit higher risk of having a miscarriage, but you can still have a normal pregnancy and having some vaginal bleeding and maybe some mild abdominal pain. Those are nonspecific symptoms. The second one is obviously more worrisome, an ectopic pregnancy. And then you could be having a spontaneous abortion at that point, and that beta-HCG is on its way down. So if the patient remains stable, and I mean really, really stable, you don't want to mess around with someone with kind of iffy symptoms or iffy vital signs. You can follow this patient with serial beta-HCG. So remember, we've talked about this ad nauseum. Beta-HCG should double every 48 hours in a normal pregnancy. So in an ectopic pregnancy, it's not going to double that often. If it's a spontaneous abortion, then it's going to be going down. You also want to do some follow-up ultrasounds as well to kind of confirm to see if something has changed. Now, an intrauterine pregnancy should be visible at a beta-HCG of 1500. So if you're watching your beta-HCG and it reaches that 1500 mark or a little bit higher than that as well, then you ought to be able to see it. And if you don't, then that puts you at a higher risk of actually having that ectopic pregnancy. Always remember though, immediate action should be taken if the patient's pain or status changes at all. So if all of a sudden there's a lot more vaginal bleeding, or there's a lot more abdominal pain, or the patient has a lot of tachycardia or has blood pressure issues, you don't want to mess around with this. You want to really get the diagnosis down and then take measures as needed at that point. All right, so that's going to conclude our quick review. Let's get back to the lecture.
Incompetent cervix. That's our next complication of pregnancy. This is a weakening of the cervix to allow unexpected dilation, and it is responsible for about 15% of second trimester miscarriages. Now, classically, this is defined as painless dilation. It'll be often associated with increased vaginal discharge or preterm premature rupture of membranes, or the abbreviation for that is PPROM. You'll hear it called PPROM. Risk factors for having a weakened cervix and incompetent cervix: prior cervical surgery, such as a treatment for abnormal pap smears like a cone biopsy, or a procedure that's called a LEEP procedure, loop electrocautery excisional procedure. Prior cervical trauma, either from having lacerations from childbirth or having multiple DNCs before, multiple dilations of the cervix. Uterine abnormalities such as DES exposure, I mentioned that a little bit earlier, medicine that was given to some moms during their pregnancies several years back, probably last used in the 70s, caused birth defects in the uterus, vagina of developing daughters of those pregnant mothers. However, most cases do not have an identifiable risk factor. So the diagnosis is clinical, and as I said, the classic histories of painless dilation or the presence of hourglassing membranes. What hourglassing membranes are is if you have a patient come in, she's complaining of pressure, you do a speculum exam, and you see membranes ballooning out at you. The reason why it's called hourglassing is because on an ultrasound, you'll see the bag of membranes, goes through the cervix, and then the bag inside the uterus, and it's shaped like an hourglass. However, usually the the presentation is usually less obvious than that. Patient comes in with mild cramping, some bleeding, some pressure, maybe has PPROM'd, the early rupture of membranes. And so what it's classically described now is that there's a spectrum between preterm labor on one side, incompetent cervix on the other side, and then the patient, it probably exists somewhere along this spectrum rather than just being one or the other. So when we think about that, preterm labor